Hi, my name is Tai Chong Zheng. I'm a hepatologist from the National Taiwan University Hospital in Taiwan. In the following 4 minutes, I'm going to tell you how our research team used a large cohort study to explore the relationship between the core-related antigen level and the risk of HBV-related HCC. Chronic HBV infection is an important global health issue, which resulted in nearly 1 million deaths per year. One of the major causes of death is hepatocellular carcinoma. Therefore, it is quite important to identify the patient at high risk of HCC. Recently, Hepatitis B core-related antigen has emerged as a new biomarker to be associated with active HBV replication. The goal of our study is to investigate whether core-related antigen level could be used to predict HCC risk, especially in patients who may not need antiviral treatment. To address this important issue, we conducted a retrospective cohort study, which included 2,666 patients with chronic HBV infection. All of them did not have liver cirrhosis at baseline, and they did not receive antiviral treatment during the follow-up. In other words, these patients are good candidates for studying the natural history of HBV. In the entire cohort, 209 patients developed HCC during a mean follow-up period of nearly 16 years. We firstly categorized all the patients by a log-10 scale of core-related antigen level. In this figure, y-axis is the cumulative incidence of HCC. We found a higher core-related antigen level was associated with increased HCC risk, and the multivariable analysis also support this finding. After showing core-related antigen level as an independent risk factor for HCC, we decided to compare whether it serves as a better predictor than HBV DNA and the surface antigen level. We then analyzed their area under ROC curve in predicting HCC development, and we found that the AU-ROC to be comparable between core-related antigen level and HBV DNA levels. Both were higher than that of surface antigen level, as our data suggests that core-related antigen level was not superior to HBV DNA. We decided to explore whether core-related antigen could redefine the HCC risk in patients with different ranges of HBV DNA. We focused on a spatial population, which included 445 e-antigen negative patients who had a normal ALT at baseline and an intermediate viral load. That is HBV DNA level between 2,000 and 20,000 units per ml. These patients are in a gray zone to initiated antiviral treatment. We found the core-related antigen level of 10,000 units per ml could identify the patient at increased risk of HCC, and the crude hazard ratio was 6.29. In conclusion, in a follow-up study of patients with chronic HBV infection, core-related antigen level is an independent risk factor of HCC, and its level of 10,000 units per ml could identify the patient with intermediate viral load but an increased HCC risk. And this data may suggest this patient may benefit more from an early antiviral treatment.